Welcome to the Leicester RadSoc Snapshot series, which is a 10-minute series focusing on important radiological topics. And our first session is on interpreting and presenting radiographs, and it has been reviewed by Dr. Hina Chottai. So in today's session, we will cover the basics of chest, abdominal, and MSK imaging with a systematic approach. So just in general, always confirm the patient details with their name, date of birth and hospital number, including the date and time of the imaging, and compare it to any previous imaging in case there have been any changes. And never jump straight to the obvious anomaly unless you are asked what the obvious anomaly is. Always have a systematic approach when you're presenting these images, and this will ensure that you don't miss anything as well. So starting off with our chest radiographs, you first interpret the image quality, and then you can do the ABCDE approach to make sure you haven't. So for image quality, you assess by RIPE, which is rotation, and then inspiration, so can you see the entire chest, how many of the ribs are visible, projection, AP or PA, so if the scapula are inside the chest, then that would be AP, whereas if they're outside, that's PA, and then exposure, so have they included the entire lung fields. And this is an example of rotation. So you can see the trachea is central and the clavicles are on either side, and they're not overlapping the trachea, so there's no rotation. And if there is rotation, it might obscure some of the signs that you would otherwise see. So moving on to our ABCDE approach, it's airways, breathing, cardiac, diaphragm, and everything else. So starting with our airway, you can have a look at the trachea, check that it's nice and central, and that's shown by the red arrows. The carni and bronchi, so indicated by the pink arrows. So you want to check that there's no foreign bodies in any of the bronchi. You want to check that they're open on both sides. And of course the right will be straighter than the left. And then you also want to check the hilar regions for any lymphadenopathy. Moving on to breathing, you can check the lung fields and the pleura. So you can see on the image that we can split it into right and left, and then upper, mid and lower zones. So that can help you identify where the pathology is and describe it to someone else who isn't looking at the X-ray. Moving on to cardiac, you can see in this diagram they've drawn the outline of the heart and labelled it for us. So you can check the heart size just by measuring the width across the diagram. So you can measure the width of the heart compared to the width of the chest, and that can be important in some conditions. And you can also check the borders of the heart, so you can see what each of the borders are comprised of here. Then moving on to our diaphragm, you can check the costophrenic angles at the bottom, so here and here, as blunting or loss of the costophrenic angles can indicate pathology. And you can also check to see if there's any free air under the diaphragm, which is important if you've done an erect chest X-ray. Then moving on to everything else, so you can check the mediastinum, the bones and the soft tissues. So here you can see that each of the ribs are labelled, and you can see the anterior and posterior ribs. You can see the cardiophrenic angle, which you would have described in the cardiac section, as well as the hemidiaphragms, and then you've got your aortic knob with your pulmonary artery on the right hand side coming down to the left hilum. And all of these different features and their presence can help identify different pathologies. And then finally, do they have any medical devices present? So is there an NG tube? Is there a pacemaker, for example? Or are there any aortic valves? And later when we come on to pathology in chest X-ray, that'll be our next 10-minute session, you'll be able to see some of that on imaging. So moving on to our abdominal images, you once again assess by image quality, and then this time it's the BBC approach. So image quality is projection. So normally they will be AP images, and they can be supine or erect. And then exposure, once again, making sure that you can visualize everything within the. So the BBC approach is bowel and other organs, bones, and then calcification and. So here you can see the bowel. So the white arrows are indicating the large bowel, which should frame the small bowel, which is shown by the black arrow. So looking at the other organs, you need to assess whether the lungs are in the picture. If there are any calcifications, you may be able to see the calcifications in the gallbladder or the bladder, for example. And the image on the right demonstrates the other soft tissue structures that you may be able to see. Then moving on to the bones, you can see many different bones on an abdominal x-ray, and hopefully you should be able to see right through to the spine as well. So here you've got all of your vertebrae labelled, and you can see there's the outline of the psoas muscles, as well as the majority of the pelvis in the image on the left. The image on the right just shows you helpful areas to check to make sure that you don't miss anything when you're assessing an abdominal x-ray. Then you've got calcification and artefact. So you could have done the x-ray for renal stones or gallstones, and if these are radiolucent, they won't appear, but if they're radiopaque, then you will be able to see them on the x-ray. You might also see vascular calcification, as well as surgical clips or foreign bodies and piercings. And again, all of these can help guide you to a diagnosis. So looking at the principles of our MSK radiography, we need to assess using multiple views, and this is really important as you might be able to see different findings on different views, and always compare to the other side if possible. So for example, when seeing a hip x-ray, you can compare both sides. And definitely if there are old images available, compare to the old images as well, so you can see the progression and any potential degenerative changes or displacement. And then you need to treat the patient and their presentation, not the x-ray. So this is really important in conditions such as degenerative arthritis. So if the patient is absolutely fine, but their x-ray is awful, then treat the patient and their clinical presentation. Always double check using the checklist, which we will go over shortly. Assess for image quality and artefact. And if you're in doubt, trace the cortices because you might be able to see a hidden fracture that way. So the checklist is ABCS for MSK. So alignment and joint space, bone texture, cortices and soft tissue. So moving on to alignment and joint space, changes can suggest various different pathologies, so fractures, subluxations or dislocations, and we would hope for a nice even joint space throughout. For example, in ACL injuries, following a segond fracture, you can have widening, which could suggest a ligamentous injury. So that's a specific example that we can use. You also have to describe the position of the fragment distal to the fracture site, and once again use that joint space. Is there any narrowing? Could that indicate underlying pathology? So for bone texture, it's important to see if there's a change in the underlying bone characteristics, which may be benign or malignant. So for example, you can have bone cysts or primary bone tumors or metastatic deposits. It's also important to assess the underlying bone density, as reduced bone density can increase the risk of fractures. And then the cortices, so it's really important to trace them. So here you can see that if you trace on the white line, it's nice and smooth, there's no breaks on either side, whereas when you're tracing on the red line, you can see that there's a fracture. So if you are in doubt, and if you're struggling to see something, just take a bit of time to trace the cortices of all the bones you can see, and then that way you won't miss anything. Then you can use your soft tissues, so any swellings or foreign bodies or effusions, that could help you to identify bony injury or indeed soft tissue injury in the case of ligamentous injury. So these are some of the different types of fracture that you can have. So from the more kind of simple transverse or oblique fractures to the more comminuted or intra-articular fractures that can be associated with ligamentous injury. So descriptions, complete or incomplete. So complete will be all the way through the bone, whereas incomplete will only be part of the bone. Open or closed, so has the bone fragments come through the skin or is the skin intact? And then displacement, and you can describe this in various different ways. So there's angulation, which is changes in the bone's axis, translation, which is movement of the fracture fragments, and then rotation, which is harder to appreciate on an X-ray. And finally, we have the Salter-Harris classification, which is for classifying fractures in kids, and it's relating it to the growth plate. So you can see the various different classifications on the screen now. So these are some of the references we used to create this PowerPoint. Radiopedia and OrthoBullets, especially for MSK, is exceedingly helpful. Thank you for listening to our first 10-minute talk. Please don't forget to fill in the feedback, and we hope to see you soon for the next one.